Hi, this is chapter 35 on headaches. The biggest part about the headaches is you have to differentiate, is it a headache, is it a tension headache, is it a migraine headache? So this is one of those cases where your diagnosis really has to be right on the money before you can start prescribing these drugs. Most patients that come to you with headaches are going to tell you that it's a migraine. So you really have to do the quiz. Is there an aura? Is it the worst headache you've had? Things like that. So if you have somebody come into your office with chronic migraines, and and you might think they would benefit from a daily medication, what are you going to tell the patient about how this daily medication is going to work and how is this going to make their life better? There's people out there who have 30 migraines a month, and for those people, their life is not okay. They miss work, they can't do social things, so they would be interested in your spiel about the daily medication. So let's go back to anxiety, where I said that it's not acceptable to only have partial therapeutic value. That's unacceptable, but for migraines, that's not true. So the goal of treatment for migraines is to reduce the occurrence of the migraine by 50%. For whatever reason, when you have these people that are plagued with the migraines, reducing them by 50% would really be great. So your first line for the abortive therapy of just a basic simple migraine, this is somebody who gets one once in a great while, is you're going to try naproxen, believe it or not. It's not ibuprofen, but it's naproxen. So if you have someone who's coming in, they say that they get a migraine once a month or once every 2 months, that's what you're going to tell them to use. And usually I tell them to drink a cup of coffee with the naproxen. So that's for simple migraines. So that's the first line treatment for simple migraines is naproxen. Now remember I told you that naproxen is the first line. I usually tell them to drink a cup of coffee or a can of Coke with it. You have somebody, there's an older drug called Fiorinol, which is aspirin and basically caffeine that's in it, and a lot of people were taking that for a long time for migraines. So you have somebody who comes in and they want to refill that. They've been taking this for a really long time. And they tell you that one dose usually, does it for them. What do you want to do? Do you want to keep them on this medication, or do you want to switch her to something else? Switch the patient to something else. So basically what you want to do, because Fiorinol is an older drug, you're going to see how often they're using it and how often they refill the medication. So any medication really, but we're going to use Fiorinol as an example. So if somebody comes in with a chronic problem requesting their refill, you want to see how often they're refilling and how much are they taking to assess see if they need the next step drug. Fiorinol is a pretty basic drug. So I would think that they're not people that have 30 migraines a month. So once again, you want to make sure you're diagnosing the proper kind of migraine. Is it tension headache, chronic, or cluster, or medication overuse rebound headache? But anyway, so this is somebody, like I said, the person on Fiorinol is usually not the person that has 30 migraines a month. So here it just tells you about some statistics. You can all read that. Here's your screening tool. This is kind of how you're going to judge. Still doesn't really tell you if it's a headache or a migraine. You're just going to have to try to feel them out. It's important to know if they're having the aura or not the aura. If they have an aura and they're a little bit older, that'll affect what kind of contraceptives they can use. And it will also, it puts them at an increased risk for stroke when people with migraine with aura. Let's see. Okay, so the abortive therapy, like we said, naproxen is first line. Mid-range analgesia is Fiorinol, which is pretty basic. Works well with some patients, doesn't work well with others. Like I said, monitor how often they're filling and is it going to work? And is it working for them? The ergos. These come in suppositories. Patients may need a pre-medication for nausea. So it's really important to know the drug reactions, the adverse drug reactions. Definitely is a rebound headache. They have vasoconstrictor effects, and these definitely cannot be used in pregnancy. They're pregnancy category X. So when you have somebody on one of the ergos, and migraine is one of them, you're going to teach your patient that they may need to pre-medicate with anti-nausea medicine, which would be like a Zofran or a Compazine. It's nice now because Zofran's PO as well. Okay, the triptans. This is, I've prescribed a whole lot of triptans already. So sumatriptan is the most prescribed drug that I've prescribed anyway, and that's your Emitrex. The interesting thing, for a while now, of the triptans, you can only get 9 tablets a month. Partially is because of the type of drug it is, and it's overused. The other thing is that if you have somebody who is using 9 triptans a month for 9 migraines, they really want you to go to a different controller medication. So it's not like they're really being stingy with them. There is a reason. And if you have somebody who's getting more than 9, you probably really need to send them to neurology anyway. Maxalt is another triptan. It's really a strong drug. They always want you to monitor your patient in the office or for urgent care center for the first dose. It's kind of scary in the office because if anything happens, you still have to call 911. Let's see. And also, you know, I wanted to go back to the Pregnancy X for your boarding therapy with your ergos, anything Pregnancy X. But if you have migraines in pregnancy, the only thing that can safely be given is a Tylenol 3, to be perfectly honest, for a really bad migraine. So that's acetaminophen with codeine. You can't give Emitrex, you can't give the ergos, you can't give DHE. So it's kind of hard in pregnancy, so know that you can only really give a Tylenol 3 for a really bad migraine in pregnancy. So if you have somebody who comes in and they tell you that they have history of migraine, doesn't respond at all to over-the-counter migraine medication, and they'd like you to prescribe Maxalt right away because their friend is taking it. First of all, Maxalt's kind of strong. I don't think I would. But if you do end up doing it, just remember that before you can give a dose, they have to sit there and take the dose in front of you. So this is one of those things where you usually don't have samples in your office either, where you're going to have to fill the med and tell them to come back and have you observe them with their first dose. So we have kids now that are totally having migraines for whatever reason, multiple reasons. Who knows why anyone gets migraines? So if you have a kid who's 14, 15 years old and they come to your clinic with a migraine, she's telling you that she has them 2 or 3 times a month. What are you going to give her? I mean, this is considered a child at 14 or 15 years old. What are you going to tell? What are you going to tell her? Think hard. So just remember, children are under 18. So pretty much what you have to do for kids is you have to give the NSAIDs as abortive therapy, and then you have to have them identify their triggers and keep a headache diary. And that is what you're going to give to kids very first, is just the NSAIDs. That's the most important thing. There's not a whole... Remember, kids, elders, and pregnant women sometimes get treated the same way. Then if you have a child who's younger than your teen, but still a child, and they've been diagnosed like a 9 or 10-year-old with migraines for a few years, and this child's missing school like a week out of each month, her headache diary confirmed she averages, let's just say 5 or 6 migraines per month, then what would you give this child? This is when you're going to go to your beta blocker, right? So you're going to give propranolol. Propranolol, actually, that is the beta blocker of choice for migraine headache. So that's Inderal. It needs to be taken daily for at least 3 months. And this is for kids. So this is the dosing, 0.5 milligrams per kg per day, and then you can increase it, and it has to be a 3-month trial. And that is a safe drug to give to kids. Remember, any beta blocker always has to be tapered off, no matter who it is. Okay, so say you have somebody who's coming into your clinic that's childbearing age, and she's a 15-year migraine sufferer. She has one at least once a month on average. She's been on a controller triptan for a really long time. She still has like a breakthrough migraine. When she's refilling and she comes into your office and she wants you to refill, what are some of the things you need to tell her? So first of all, you're going to tell her that she needs not to get pregnant on a triptan because it's a category X, and she needs to continue her monitoring her headaches and see when they're happening, if it's around her period, or is there any other preventive drug therapy that might actually work for her better. And what will the triptan interact with her antidepressants, including her SSRIs or St. John's wort, something like that? Is it going to cause like a serotonin syndrome? So those are the things that you need to ask. Let me go right here. Right, drug interactions. So MAOIs, all the triptans. This is what they interact with. SSRIs, St. John's wort. So you're going to make sure that they do all these things, and that's part of the patient education. The rest of the slides are really great information, and pretty much goes through all the different types of headaches, as you can read, and what to do about it. A lot of it has to do with biofeedback, exercise, stress reduction. Stress reduction is a big one. Knowing your signs and symptoms and your triggers for your headaches. The only other thing is the medication overuse. And I think this is where people will get into a lot of trouble. A lot of times people on Fiorinol are having this problem where they would just use the drug, stop the drug, have a rebound headache, use the drug. And it's just kind of a vicious cycle. So I think it's better if you, less is more, but you need to know if you can send them off to a headache clinic or to neurology to find out the underlying cause is the big deal. None of this, everybody knows by now, I'm not a fan of medicine, but headaches are always a little bit scary. I mean, all of a sudden now we've come up with all these people who have Chiari malformations. I had somebody come into my office who never followed up on her Chiari malformation, and she came to me for migraine headaches. I guess she had lost her insurance. Now she has insurance, and I found it by chance through the computer while I was talking to her, and I sent her right to neurology. I did give her the 9 tablets of Emitrex, the sumatriptan, but I sent her, got her referral for neurology, because that I'm not going to mess with. I'm not going to be treating somebody for migraine headaches that has a known Chiari malformation that was never followed up on. That is not somebody that belongs in your primary care office. Headaches takes you through question 90, so you're almost done. You're probably pretty excited because one more set of slides and you are done with advanced pharmacology.